The number one cause of death in the world is cardiovascular disease. Whilst healthy blood vessels can successfully deliver blood to where it's needed when they become narrowed or blocked, serious illness and death can follow. This is particularly the case when narrowing occurs in the coronary arteries that supply blood to the heart muscle itself. The state-of-the-art procedure to reopen narrowed coronary arteries involves the minimally invasive deployment of a stent. In the majority of cases, treatment planning and device selection are primarily informed by X-ray angiography.
The optimal way of deploying a stent is by looking at it from the inside of the artery using various intravascular imaging techniques. However, because this requires extra training and expertise, it's often the case that cardiologists will put stents into patients just based on an angiogram. A lot of the problems of deploying stents can be overcome using a technique called intravascular ultrasound, or IVUS.
Given the advantages of IVUS, it's surprising that across the Western world, this method is used in less than 10% of all stenting procedures. The reason for this is the difficulty of interpreting IVUS images, especially for relatively inexperienced cardiologists. My name is Neil Bresloff. I'm a professor of biomedical engineering and design.
My name is Nick Curzon. I'm a consultant cardiologist who specialises in aortic and coronary intervention, and I'm Professor of Interventional Cardiology at the University of Southampton.
Together, we've developed a visualization software that brings new insight into angiography and IVUS imaging, allowing even inexperienced cardiologists to make the best decisions for their patients. We're setting up a company called Carena to commercialise this technology and allow it to support clinical decision-making right around the world. Our technology works by using algorithmic techniques to generate three-dimensional models of diseased coronary arteries. Once constructed, the models can be manipulated and analysed.
It can be automatically built into a three-dimensional fly-through picture for the clinician, which will help them tailor their therapy and ensure that the stent deployment is optimal.
Furthermore, stents can be selected for the specific patient, and the decision-making process is directly linked to the geometry of the vessel and, most importantly, the disease. These tools can be applied to a wide range of other diseases and imaging methods as well. We decided to set up Carena Healthcare, having demonstrated how our software has the potential to significantly improve the clinical decision-making process, with the intention of establishing industrial clients, partners and licensees from imaging and related high-tech medical instrument companies in the UK, Europe and North America. Additionally, we plan to raise significant product development funding in the next 6 to 12 months. With this support, we will clinically validate the software toolkit in preparation for regulatory approval. It is our aim to distribute the toolkit to catheterization laboratories around the world.
I believe this type of research could make the patient outcome routinely better, as long as we provide clinicians with a much easier tool so that they are happier to use it and feel freer to use it routinely in patients.
If you'd like to learn more about the Carena Healthcare Medical Software Kit, please get in touch.